Well, thank you so much to obviously my chairs for the opportunity to present today. It certainly is a pleasure and a privilege to be here. I'm Erin Baker. I'm an associate professor of surgery at Carolinas Medical Center, which is part of the Atrium Health Network. And so in going forward with my talk today, I'm happy to say that Dr. Zirkat is not here to offer a rebuttal, so that's nice for me. And I will say that I am a laparoscopic surgeon. I'm 5 years into my practice now. I do all of my distal pancreatectomies that are within reason laparoscopically. And so this talk is a reflection of my past, but probably not a reflection of the way that my future will be. I'll just add that caveat there at least. And so these are my disclosures, not relevant to today's talk at all. So in discussing laparoscopic distal pancreatectomy, we were asked to kind of cover these areas, including implementation and safety, clinical outcomes, cost, and ergonomics. And so it was certainly an interesting review of the literature to kind of think of my approach to this talk today. So here's what I want to start with. I want you to think about how surgery training is going, at least in North America, in the United States and Canada predominantly today. So you start off as a medical student, and you are progressing from your time as a student to now your time as a surgery resident. And as a surgery resident, we are learning a lot of laparoscopic procedures. But I would say that the use of robotics in surgical education training is largely pretty varied. While it takes time to develop the curriculum that we need to be able to do these procedures from both a laparoscopic and a robotic basis, on a general statement, the vast majority of training programs, at least in the United States, are not equivalent in terms of being able to adequately train residents to do advanced and complex robotic experiences. Now, while that will vary from institution to institution, if you have a strong robotic presence, I would still argue that there's a lot of training programs which are probably not training residents to be able to do robotic-assisted procedures without advanced training, meaning going on to do an MIS fellowship that includes specifically robotic surgery. And certainly, it's very difficult to go from being a surgery resident to being a robotic surgeon straight out of the gate, again, without that additional experience or additional time. And largely that comes from the fact that the past 10 years, everyone who is a current faculty member has just been starting or implementing the robotic-assisted surgery program. So those people have been still in their learning phase, still trying to overcome those challenges. So how can they adequately let our surgery residents be able to get enough time on the console to then go out and start this into practice? And certainly, I would say it's not the case for robotic pancreas surgery. So there are very few robotic HPB training programs, and actually I come from one institution where we actually offer a dedicated one-year robotic HPB program with one of my partners, Dr. John Martini. But really these opportunities, I think, are extremely rare outside of specialized centers like UPMC. So in terms of implementation of how do we become a distal pancreatectomy surgeon who can do this in an MIS fashion, you know, if we go back to kind of the LALAP study, so this was published in 2016, and this is from the Netherlands. So this was the implementation schematic that was allowing surgeons to take on laparoscopic distal pancreatectomy procedures. So they did some technique descriptions, some video trainings, and then on-site proctoring or off-site proctoring until they were deemed ready. And really what they saw with the implementation of this program was that they were able to increase the number of minimally invasive, laparoscopic distal pancreatectomy procedures from 9% up to 47%. And then also significantly reduced their time to, or reduced the number of conversions significantly over time. So I think that from an implementation standpoint of having a generation of surgeons who is already familiar with laparoscopic assisted surgery, being able to implement a laparoscopic distal pancreatectomy program is probably easier than if you have no background in robotic-assisted surgery. So this is basically a meta-analysis that was done in preparation for the Miami Consensus Conference. And so this was basically looking at a bunch of different papers to try to discuss what was the learning curve to performing MIS distal pancreatectomy procedures. So LAP learning curve, 10 procedures, maybe 15 is what was quoted from this series of studies. But from this series, robotic learning curve was 37 cases. I'll granted that that number probably seems a little bit high, and largely that's going to probably be coming from the fact, again, that many people were probably still in their learning phase of learning to do, I'm sorry if I'm putting the green dot on your head, but learning to adjust to robotic-assisted surgery. So again, these were probably surgeons who were laparoscopically trained and then we're taking on that role of robotic-assisted surgery. So to overcome that learning curve of 37 procedures, I think ultimately is probably not going to be true in the future as we continue to train from a robotic standpoint. Safety, in general, the vast majority of studies that I saw showed that there's no significant difference in overall complications, severe complications, or postoperative pancreatic fistula. So I would probably make the argument that both robotic and laparoscopic distal pancreatectomy procedures from a safety standpoint are going to be equivalent. However, there was a significantly shorter time in the OR in the vast majority of studies. Now, from the UPMC data, which if you happen to live near Pittsburgh, that is fantastic, and they offer a robotic program that is unparalleled. I think that the vast majority of studies to date, though, have not replicated this in the rest of the world, and a lot of studies have actually quoted shorter times in the operating room with laparoscopic-assisted procedures. In terms of oncologic outcomes, obviously similar oncologic outcomes between both laparoscopic and robotic. I will give it to the robotic side that there is a higher rate of splenic preservation that has been quoted with robotic-assisted surgery. And there have been studies which have reported shorter length of hospital stay with robotic-assisted procedures, and ultimately I can't tell you that I know exactly why that is. I come from an institution where we have a fairly robust robotic and laparoscopic program, and I feel like our patients stay the same length of time. Our incisions are going to be essentially the same, maybe even slightly smaller for a laparoscopic approach. And so ultimately, I'll say that I feel like you have to make sure that you're comparing appropriate cases. I certainly cannot do a celiac axis resection laparoscopically. That's just not in my skill set. But I do think that in general, the outcomes are certainly probably the same for laparoscopic versus robotic. Now, again, the one thing I would argue is that in multiple studies that there was a shorter time in the operating room, and so I'll let that translate to whatever it is that you want to take from that, meaning theoretical lower rates of potential pulmonary complications or perhaps DVTs, but ultimately as we overcome the learning curve and our time to do either a laparoscopic or robotic distal pancreatectomy decreases, I think ultimately all of those potential complications are mitigated. In cost, so many studies, and I went back and forth trying to decide what I was going to say here about cost. Ultimately, what I would say is that, as Dr. Zerkat pointed out, from a general equipment cost alone, this is probably going to be higher for robotic-assisted procedures. Nowadays, though, we're trying to prove our point. So if there is truly a shorter hospital stay, then when we add that in, along with total outcomes, it's potential that cost could be negligible between laparoscopic and robotic. I think ultimately what's going to happen is that market competition is going to continue to drive costs down, but we have to be on the lookout for new technology, right? Anytime there is something new that comes our way, there could be actual potential costs associated with that are actually going to drive the cost potentially back up again. So, laparoscopic technology has largely been the same, at least for the past, 10 to 15 years of my training, except with a couple of great and interesting new advances. But I think what's going to be seen in the forefront with robotics is going to potentially help determine some of that. I'll wrap up here. Ergonomics, I'll concede. I think that probably robotics is probably better for ergonomics, but conversion is obviously much easier for laparoscopy. And although Dr. Zerkat has rightly pointed out that we look to conversions as being a bad thing, but in general, in someone who is still training and still learning, I don't necessarily think that conversion is a bad thing. I think that if you're stuck in a case, if you're still overcoming your learning curve, the option to being able to put a hand in to do a hand-assisted laparoscopic procedure can actually be extremely useful and actually very safe for the patient. And so it becomes much more challenging to convert from a robotic-assisted procedure because many times if you're going to convert, there's not a great hand-assisted robotic option. So with that, I will wrap up and just go ahead and turn it back over. So thank you very much.